Maddie, we cannot hear you. Sorry. No, we cannot hear.
All right. Can you hear me now?
Yes, yes.
Okay. I'm just going to start from the beginning. So apologies for people in here who already just heard this, but welcome everyone to a joint University of Colorado and CP Solvers virtual morning report. Today's session is in honor of Dr. Rafael Medina, who we will talk much more about in a little bit. But just to first introduce myself, my name is Maddie Conti. I'm an incoming internal medicine intern, and I'm also the co-director of internal operations at the Clinical Problem Solvers. So today's session, we'll talk more about Rafa soon, but today's session is actually a joint rheumatology and pulmonary critical care medicine VMR, and we are very privileged to learn from two amazing educators at the University of Colorado, Dr. Jeff Connors and Dr. Melissa Griffith. We'll hear more about their introductions soon, but I wanted to just kind of give an overall agenda for how the session will go today because it's a little bit different than other ones. So the session, because it's in honor of Dr. Rafa Medina, I wanted to take some time to share what a phenomenal human he was and share some stories about how I knew him. We'll then jump into a case discussed by Dr. Griffith and Dr. Connors and presented by two of the outgoing chief residents, Sarah and Evan here. And then at the end of the session, we will show a slideshow of some photos of Rafa and also hear from, really anyone who wants to share some words, but we'll definitely hear from one of his mentors, Ravi Singh. And then also just to acknowledge that it's Juneteenth today, so I really appreciate everyone for being here. And it's really so good to see everyone in person and a lot of people online. So thank you for taking the time to be here. So to start talking about Dr. Rafael Medina. So as we called him Rafa, so Rafa was an international medical graduate from Brazil who really transformed medical education around the world, which I will talk about briefly. So I came to know Rafa through the Clinical Problem Solvers. He was the one who actually invited me to join the team several years ago and gave me some of the first opportunities I had on Virtual Morning Report. And over the several years I knew him, it was truly amazing to witness the incredible educator, leader, innovator, and friend that he was to people all over the world. So just to give an example of that, one of the many projects that he helped to lead and spearhead was something called the Subspecialty Series, which is now on the podcast and happens on CP Solver's Virtual Morning Report every single Monday. And just to kind of walk through a little bit what this entails, he cold emailed subspecialists and leaders in their field around the world to ask them to discuss a live unknown case for free, and that this would be disseminated to thousands of learners around the world. And many of them said yes. We've now had more than 130 subspecialty episodes, all thanks in large part to the organization and leadership that Rafa helped to spearhead. And that was just one of his projects. He led so many IMG projects and many others. But really, when I think about Rafa, what I'm left with thinking about the most is how he prioritized mentorship and lifting other people up. When he transferred the leadership of the subspecialty series over to me, the piece of advice that he gave me was to use every project and every series as an opportunity to give opportunities to others, as a opportunity to lift others up. And through all of the projects that he led, he was constantly focused on mentorship and lifting other people up. And then the last story I wanted to share was that I had the privilege of spending a whole day with Rafa. He came to visit New York City, where I was in medical school, and we decided to spend the day together. And it was a very cold day, so I suggested going into a museum, maybe eating inside, but he had such a huge appetite for life and said, no, Maddie, no, I want to go to Central Park. I want to see the Empire State Building. I want to go to the High Line. So we spent this frigid day in New York going all over the city. And I think it was just a beautiful example of his appetite for life. And the last thing I'll say is that on his Twitter, many of us know that he has this quote, "One life, so many dreams." So I will challenge us all to have the courage to dream like Rafa, but more importantly, to lift others up along our journey, just as he prioritized. So I wanted to share that about Rafa, and at this point, we'll now transition to the case. But first, I want to thank a few people and then pass the mic for some translation into Portuguese. So first, I want to thank several people who are helping to make this happen. First is several of the outgoing chief residents of Porva, Sarah and Evan, who have done a lot of logistical work to make this happen. I want to thank Garrett Westcamp, an incoming PGY2, whose initial idea was to do this session in honor of Rafa. And then I also want to thank Deborah, who is there online, who's a CP Solvers team member who will graciously be translating parts of this introduction into Portuguese right now so that Rafa's family, who is tuning in to this and who watches the recording later, can understand. So before we transition to the case, I'll now pass the mic to Deborah for the translation. Thank you so much, Deborah.
Olá a todos, boa tarde. Hoje, nosso time do CPS Solvers está muito feliz em fazer esse episódio homenageando o Rafael. Ele era um grande amigo, um grande filho, um grande médico, um grande irmão. E eu quero agradecer todo mundo do Brasil que está aqui no Zoom, que vai assistir essa gravação depois. Quero agradecer a família do Rafa, que sempre apoiou o nosso trabalho. Eu espero assim, que um dos nossos objetivos seja sempre honrar toda a dedicação que o Rafa sempre teve durante a jornada dele no CPS Solvers. E a Mary, ela fez uma introdução falando um pouco sobre ele e eu vou traduzir o que ela disse, né? Ela comentou que o Dr. Rafael Medina era um médico formado no Brasil, e ele deu o match, né, que a gente chama, ele foi aceito na residência da Universidade do Colorado, mas infelizmente ele faleceu, né, de uma forma trágica e antes de poder começar a residência. E a Mary compartilhou que, desculpa, às vezes pode ser que o meu português com o espanhol deu uma mesclada, mas ela compartilhou que ela foi convidada para participar pela equipe através dele, e que durante 2 anos ela teve o privilégio de ter contato com ele, que é um grande educador, brilhante, sempre inovador e com uma excelente liderança. E para exemplificar, um dos projetos que ele criou foi uma série de episódios direcionados a especialidades médicas, que agora também é um podcast. Para desenvolver esse projeto, ele mandou e-mails para médicos no mundo todo para discutirem um caso relacionado a uma especialidade médica, por exemplo, cardiologista, nefrologista, endocrinologistas e casos que médicos não tinham a menor informação a respeito. E os médicos aceitaram, e até o momento nós já temos mais de 130 episódios com especialistas de todo mundo, e esse é um dos muitos projetos que o Rafa deu início. E o que, além disso, era muito impressionante a criatividade e liderança dele, como ele marcou a forma de se relacionar com as pessoas, sempre preservando a mentoria, sempre elevando o time junto com ele, assim, na jornada dele na medicina. E ele prestava atenção nos mínimos detalhes. Ele queria ajudar cada um a escrever uma carta sobre si, organizando episódios ou realizando uma mentoria com algum dos membros. Ele sempre conseguia enxergar o potencial de cada pessoa e não medir esforços para que aquela pessoa alcançasse os seus objetivos. E, por último, a Mary falou que ele foi para Nova York, que eles passearam, que tiveram um dia lindo lá e que ela tem uma memória muito boa dele de felicidade, cheio de vida. E finalizando no Twitter, né, a página na internet, ele tinha uma frase, uma vida e tantos sonhos. Que todos nós possamos ter, né, a coragem de sonhar, mas também de erguer e elevar pessoas durante o nosso caminho e conseguir alcançar tudo que a gente almeja. Nada, essa é um pouco da tradução em português. Thank you so much, Maddie. I'll pass to you.
Deborah, can you hear me, by the way?
Yes, I can
Do you
hear
have-
you.
That was amazing. And thank you so much for translating that on the spot. That was beautiful. And I realized that I was so, excited to talk about Rafa. I didn't kind of explicitly mention that I realized I didn't explicitly mention that he matched here for internal medicine last year and tragically passed away prior to starting. And apologies for not just explicitly saying that at the beginning. Deborah, thank you so much for doing that translation. So we're now going to transition to the case part of this. So I'm going to pass the mic to the outgoing chief residents, Sarah and Evan, to maybe briefly introduce yourselves, and then you can introduce our amazing case discussants.
Yeah, thank you so much, Maddie. I'm Sarah Hager.
Hey, and I'm Evan Zaire.
Yeah, we are two outgoing chief residents. I'm about to start nephrology fellowship at University of Washington.
And I'm starting a pulmonary and critical care fellowship at Vanderbilt.
We'll be introducing our discussants today. So I'll introduce Dr. Melissa Griffith. Dr. Melissa Griffith is an assistant professor in rheumatology at the University of Colorado. She works in a multidisciplinary team specializing in caring for patients with autoimmune interstitial lung disease. I had the very good fortune of working with Dr. Griffith during my intern year during a rheumatology elective. She was an outstanding, enthusiastic educator, and it was an amazing experience getting to learn from her. I'm excited to learn more from her today.
And then I have the privilege of introducing Dr. Jeff Connors. He is an associate professor in the Division of Pulmonary Sciences and Critical Care Medicine, and is currently the associate dean for graduate medical education at the University of Colorado School of Medicine. And before starting that role this spring, we were fortunate enough to have him as the program director here for the internal medicine residency program. And so with those introductions, I'll pivot into the first aliquot of our case. And if we want to pull up the share screen for the scribe as well.
Yeah. Carissa, you can go ahead and share your screen. And Carissa, thank you so much for scribing, and Elena for jotting down the teaching points.
All right, and so for our first discussants, this first aliquot of information is going to cover the chief complaint, HPI, and history for this patient. So the chief complaint is a gentleman coming in. He says, I feel tired all the time and my muscles hurts. So this is a 50-year-old male with a history of prior gallstone pancreatitis, status post cholecystectomy, who presents with a chief complaint of fatigue and muscle aches. He was in his usual state of health until about 1 month ago, and then he developed significant fatigue, weakness, and migratory arthralgias a few days after returning from an elk hunting trip in Colorado. He more specifically feels that he has lost the energy to do his normal tasks and feels that he has to lay in bed. He does note associated chills and sweats, but no associated hemoptysis. Weakness is most notable in his legs. He feels that he cannot even lift his knees at times and that his knees buckle. His migratory arthralgias involve his knees, shoulders, hands, and ankles, and he feels that his joints appear swollen and red. A few days after this symptom onset, he developed a purplish discoloration around his eyes and knuckles, along with a dry cough and exertional dyspnea that limits his ability to walk multiple blocks. So for his past medical history, as I mentioned, the only thing is notable is gallstone pancreatitis, which he had a cholecystectomy but has no other surgeries. He's not taking medications currently. He denies a family history of cancer, blood clots, or other autoimmune diseases. And then he lives with his wife in rural Colorado. He works in agriculture and has had recent exposures to a variety of animals, including elk, ducks, goats, and pigs. He was incarcerated remotely 30 years ago for a brief period of time, occasionally smokes marijuana, denies tobacco or alcohol use, and he has no allergies. So that's the end of aliquot 1.
Thank you so much, Evan. So we have two amazing discussants today. Maybe Jeff, Dr. Connors, we can start with you. And I know that was a lot of data, so we're really interested to hear kind of what's standing out to you out of all that information. What do you feel like is pertinent at this time? And thank you so much for being here, even though you're a little sick.
Yes, that's okay. I'm happy to be here. I'm sorry I'm not in person. I have touched with the COVID, but I also want to just start by saying, thank you to Rafa and to his family. I was the program director when we took Rafa into the program. I was so excited to meet him and to get to work with him, and just really pleased that we can do this in his honor. I will say that I am a professional lung doctor and an amateur rheumatologist, so I'll defer to Dr. Griffin for a lot of these things. But I am struck by a couple of things. You know, he mentions both fatigue and weakness, and I think we often lump those together, but that's going to be really important to define. Is he tired because of the systemic illness, or is he truly muscularly weak in a way that he wasn't prior to this? The social history is, of course, super interesting. Some of these are going to be red herrings. Some will be real, but exposure to animals, you know, you think about the zoonoses, so tuberculosis, mycobacterial disease, brucellosis, et cetera. The fact that he works also in a place where he can have work-related exposures is potentially interesting. The fact that he is a he may be interesting as we think about autoimmune diseases, in which show up more commonly in men than women, which is not many, but a few. You know, thinking IBM or something like that, especially in a man in his 50s. And then, of course, you know, I think I'm here because he's got this dry cough. And so I'll turn it over to Melissa for the rest of the room stuff, but there is a lot of overlap between rheumatologic disease and lung disease, autoimmune lung diseases in particular, primarily because the lung is a filter. And similar to other organs that have fine-tuned machinery plus small vasculature, we think about the kidneys, we think about the eyes, a lot of what lives systemically lands in the lungs. And so we can talk more about that as we get into his physical examination, because I think the examination here and the pattern of what we're seeing is going to be incredibly informative, both the muscular pattern as well as these defined skin lesions, which may be heliotropes, gotrons, et cetera, but we'd want to hear more about that.
So,
Dr. Griffith, what are your thoughts?
Great thoughts so far. I think this is, I think the timeline, the time course, first of all, is like, this is kind of a subacute onset. This isn't overnight this happened, but after his hunting trip, it's kind of slowly progressed and occurred. So that's like one of the first things, and more typical for some of our autoimmune diseases like myositis, or most of them are generally more subacute to chronic presentation. And then, as Jeff mentioned, as far as the muscle stuff goes, the weakness, defining, is it true weakness or just the feeling, like subjective feeling of weakness, is really important. So like getting a little bit more information about the weakness and the things that are limiting him. So like the things for myositis we're typically asking are, do you have trouble getting up out of a chair? What about showering? Are you having trouble showering? Because a lot of our patients have trouble actually just shampooing because they're so weak proximally. And so that like proximal more than distal weakness is generally more of a feature of myositis, but all of rheumatology doesn't play by these rules. So a few diseases can do some different presentations, but most of our myositis diseases will do that. And then a little bit more about the joint stuff. So it sounds like he's noticing some swelling as well. But like learning a little bit more, does he have morning stiffness? And like what's making the joint pain better or worse can help us define more. Is this like an arthralgia? Is this inflammatory arthritis? Those are things that kind of help like put more of our weight towards like a rheumatologic cause to these joint pains that he's having. And then as Dr. Connors mentioned too, like the dyspnea on exertion and cough are all, we're seeing that like probably multiple systems are involved. And so that also kind of goes along with like that we're thinking something along the rheumatology line, you know, that it's not just one system. But like joints, muscles, lungs all seem to be involved, but we're still thinking about our differential and thinking about what he's exposed to. Like he's, like Jeff said as well, like he has a few occupational exposures and environmental exposures that could make him more at risk for like pulmonary disease and some other things. So yeah, initial thoughts.
Those are brilliant initial thoughts. If I could just ask one follow-up question before the next aliquot. I'm curious, you mentioned kind of given the time course and the constellation of symptoms, potentially a concern for myositis. And I was curious if you could talk about what aspects of the past medical history and on physical exam would you really be keeping an eye out for that concern?
Yeah, so as far as like past medical history, there's not necessarily like one thing that would like put somebody at risk, except for there's kind of this bimodal distribution of myositis that we can see it in like the juvenile to early adult population, and then we have like another distribution later in like in your like 50s, 60s, 70s, and so we can the age that could be one thing. And then as far as like the physical exam, and he was kind of already mentioning this in his history too, that I forgot to mention, is that, you know, he's having skin rashes around his eyes. So like that's already, I'm looking on exam for something to be described like a heliotrope rash, looking for other cutaneous manifestations of myositis like Gottron's. You can have the kind of V-neck sign or the shawl sign. You can also have the holster sign on the legs. So looking for those things, and then looking on exam for inflammatory arthritis, and then on strength exam that we're looking for like a decreased strength again, like proximal more than distal. So those are the kind of big things. You can also see other cutaneous features, but I won't bore you with all of them, but yeah.
I'll also I'll add to, I think, you know, the terms get confusing. You know, myositis is really the most broad, the most umbrella term here. You know, anything that is causing an itis in the muscles. You know, what we're starting already to hone in on are the idiopathic inflammatory myopathies, those things that, you know, do have this bimodal distribution and are, you know, have a more narrow reason for causing them. And the other thing just to throw out here is that, you know, occasionally we'll see these things as manifestations of paraneoplastic syndromes. And so this may be, it's a man in his 50s, somebody who has some other thing that's causing what we think we're seeing that we're going to discover as we move on.
Yeah, excellent point. And I think like it's good to keep a broad differential even within myositis, because we frequently can see a lot of different manifestations. And so not all CK elevations are inflammatory myositis.
Amazing teaching. Well, to the next aliquot.
Alrighty, so aliquot 2, his temperature was 37.7 when you were seeing him in clinic. Heart rate was 68. Blood pressure was 104 over 63. His respiratory rate was 22, and he was statting 97% on room air. For his constitutional exam, he was calm appearing, comfortable, although a little bit fatigued, and in no acute distress. For his ENT exam, his pupils were equal and reactive to light. He had a violaceous rash involving his periorbital area, no scleral icterus. His neck was supple without lymphadenopathy, and he had moist mucous membranes. His cardiovascular exam was within normal limits. For his respiratory exam, he had normal respiratory effort, but some faint bibasilar crackles. His GI exam was largely unremarkable. For his MSK exam, he had no synovitis, enthesitis, or dactylitis. And his motor strength testing, unfortunately, was limited due to pain, and so was not documented in that initial visit. For his skin, in addition to those findings around his eyes, he had some violaceous discoloration over his MCP knuckles on the dorsum of his hands, and some also on his bilateral wrists. And then he also had some cracking and fissuring involving the first 3 fingers, predominantly on the tips, and then had some healed ulcers involving the palmar surface of his thumbs bilaterally, and also his left index and middle PIP on the palmar side as well. And then for his neuro exam, he was ANO ×3. He had sensation that was intact to light touch, was moving all extremities, and had 2+ patellar reflexes. So that's the end of aliquot 2.
So maybe we'll start with you, Dr. Griffith, and would love to hear what's standing out to you in this physical exam and how you're incorporating that with the other data we had.
Yeah. So I mean, you're reporting some skin findings that would be concerning for more of a like dermatomyositis. The things that so we're seeing like that violaceous rash around the eyes, the cracking and fissuring in the fingers. We can see with some like a subset of dermatomyositis, we can see with like an antisynthetase syndrome, we could see like this kind of mechanics hands. And with antisynthetase syndrome, like the risk of interstitial lung disease is quite high. And so already when I'm seeing mechanics hands on exam, I'm like really quite concerned about the lungs. Interesting that he didn't have synovitis, but because he had a lot of pain and reported. So that's one thing that we can see with antisynthetase. We can see inflammatory arthritis, but it sounds like this, based on the exam, it might be more like arthralgias that he's having more than anything. And then for his strength exam, which is not documented, but it's interesting that he's having a lot of pain, which is not typically a manifestation of inflammatory myositis. So like pain more than weakness is usually the opposite of what we see. So it's hard to say with that documented exam, like what is going on within the muscles. The only other thing I'll say is that the ulcers are also concerning. I can't remember where you said they were at.
Yeah,
It's like on the.
And I also, or if you want to pull up, we had some representative
Oh,
pictures
yeah.
of how
Oh, yeah.
what stuff looked like, but it was on the ulcers were on the palmar surfaces of thumbs bilaterally. And so these are not him, but just some kind of representative images for folks in the room and
Okay.
online. But the ulcers were involved in the palmar surface of his thumbs bilaterally, and then his left index and middle PIPs on the palmar side as well.
Okay. As we can see, like ulcers with like more like malignancy associated dermatomyositis, or we can see it with like MDA5 dermatomyositis. And so whenever we start to have ulcerations, and it starts kind of like me thinking more along those lines, that those, like making sure we're looking for malignancy and things like that.
Yeah, and Dr. Connors, would love to hear if you had any additional thoughts to the physical exam. And I thought this would also be a helpful time. You know, you all have mentioned so many amazing teaching points about myositis and dermatomyositis. And for folks tuning in who may not be as familiar with how myositis is classified, would you be able to kind of walk through how, in your mind, you think of kind of the breakdown of myositis?
Yeah, for sure. I will. I may defer the breakdown of myositis to Melissa. I can say all the things like Bohan and Peter criteria, but she actually knows them better than I do. But yes, so I will say from a lung standpoint, just specifically, the most concerning thing is obviously the crackles. You know, there's a couple possibilities here, and as common as anything else is that these patients are weak and therefore feel short of breath. So breathing 22 times a minute doesn't surprise me if each of those breaths is 60 or 70% as big as they should be. But the fact that this person is, you know, has tachypnea plus the crackles means that not only may their muscles of respiration be weak up to and including the diaphragm, but that they also have some sort of interstitial lung disease. And as Melissa said, you know, now we're really getting into antisynthetase syndrome, where, you know, the incidence of lung disease, depending on the autoantibody, can be up to 85%. And so it's very common to have lung involvement, not just the muscles of respiration, but the actual parenchyma itself. So that's my concern there. And then, yeah, I think, you know, I'm assuming you're holding off the muscle exam for aliquot number 3, although that would be the first thing I would do when I walked in this room. And for those who've been on rounds with me, you know, I like to order the things in order of importance. And so I would be doing a muscle exam on this person, you know, before I did almost any of these other things. So hopefully we'll get that in a second to help us. But maybe I'll turn it over to Dr. Griffith for the description of how we define myositis.
Yeah, so as Jeff mentioned earlier, that like myositis is just inflammation in the muscles, and you want to define, like, we want to separate like myopathies from myositis. And so like there's a lot of causes of myopathies, mostly genetic. So you can have a variety of myopathies, and that's like a thing that we commonly get called in the hospital, is like trying to figure out what this new patient's CK means. And so trying to separate the two is important. And so like we've already talked a lot about like inflammatory myositis, which would be the autoimmune causes, but then we want to also remember that like infectious myositis is relatively common. And so that's on the differential, and we've seen that not infrequently. You can have it like viral, bacterial, like other like fungal infections that can do that, and parasitic as well. And then we've also seen like neoplasms in the muscles, and so that can cause a myositis presentation as well. So But as far as like inflammatory myositis, which is more my niche, is there's like kind of the older descriptions, which was dermatomyositis, which is just skin plus muscle, and then polymyositis, which is just muscle plus other things. And now we're kind of moving away from that in rheumatology to more defining based on the antibody that's positive and like what that antibody might predict about the patient. But anti-synthetase antibodies are kind of what we were talking about, like with anti-synthetase syndrome, that those patients can have skin manifestations, muscle, joint, lung. They can have fevers, they can have Raynaud's, and so they can have a variety of things. So that's kind of like a subset within a dermatomyositis.
Amazing. Thank you both so much. All right, next aliquot.
All right, so we'll go ahead and move into aliquot number 3. Unfortunately, we will not get a better strength exam. I guess
Dr. Hager.
I know. The strength exam was very limited due to pain. It seems like a little bit later, once they had better pain control, they were able to get a little bit better of a neuro exam and strength exam. And the patient did have 4 out of 5 strength in proximal, bilateral, upper and lower extremities, 5 out of 5 strength more in the distal extremities. But we'll go ahead and get into kind of some of those basic labs, and I'll report them first with some of the ones that returned first. So just for a basic workup, the patient had a CBC. The white blood cell count was 10.4. Differential showed 72% neutrophils, 17% lymphocytes, 1% eosinophils. His hemoglobin was 14.1, hematocrit 42.7, platelets were 194. Sodium was 136, potassium 3.5, chloride 107, bicarb 21, BUN 13, creatinine 0.96, and glucose 99. Calcium was 8.7. For LFTs, the patient's total protein was 6.0, albumin slightly low at 3.1, total bilirubin was 0.9, AST mildly elevated at 51, ALT 45, alkaline phosphatase was 106. Given that the team was also concerned for inflammatory myopathies or myositis at this point, they also got a CK and aldolase. The CK was actually normal at 38. Aldolase also normal at 4.5. They also got chest imaging given the patient's crackles and dyspnea. The chest x-ray showed increased coarse bibasilar opacities, which could represent interstitial lung disease or pneumonia and pneumonitis. There was similar coarse interstitial left mid-lung zone opacity suggesting scarring. The patient had a normal cardiac size and no large pleural effusion. They also got a CT chest, which showed left upper lobe and bibasilar predominant peribronchovascular, irregular, consolidative, and linear opacities, with mild associated architectural distortion concerning for interstitial lung disease. And that is the end of aliquot 3.
So Dr. Connors, maybe we'll pass the mic to you first, and would love to hear how you're thinking, specifically of the pulmonary findings in the context of, the physical exam that we had, and how are you thinking those might be tied together?
Sure. I will say it's a good reminder not to make fun of Dr. Hager, because then she will give you a myositis case with a normal CK. That is my punishment. So well played, Sarah. Yeah, so, what we're seeing here is a couple things. One is this is sort of just a complex description, at least by words, of interstitial lung disease. So the fact that there are linear markings, the fact that it is diffuse in all lung zones, I think it's just the fact that it is a diffuse interstitial lung disease. I don't think that means anything in particular. I will say, you can have these bibasilar markings, you have peribronchovascular markings in almost any of the ILDs. Whether this is going to end up being an organizing pneumonia, something more like NSIP, or even up to a UIP pattern, those can be similar across all findings. We can talk more about how the biopsy subtype determines your clinical course later if turns out to be relevant. I will say the other thing that's interesting is, the fact that we see architectural distortion tells us about timeline. That's probably the other thing that's most interesting here, which is that this has to have been present for at least, several weeks, I would say, which we already knew that this was a subclinical or subacute presentation. But the fact that there's architectural distortion, you know, this has been there for some time. So it makes infectious causes a little bit less likely. It makes more of the inflammatory myopathies more likely. And then the rest of the labs, I'll just say, are not too surprising. The fact that this person would have normal labs, you know, I think if we were still going down infectious disease avenues, and maybe we will, you know, I might expect those to be a little more abnormal. The normal EOs and normal white count, those are all reassuring. But otherwise, in the diseases that we're considering at this point, we wouldn't expect the labs to be too abnormal. Low albumin is chronic inflammation. Probably the high AST, ALT could also be related to muscle breakdown. We don't check those commonly, but they are associated.
And Dr. Griffith, of course, I wanted to hear any additional thoughts you have on this data, but specifically, how are you thinking of the normal CK and the aldolase in this case?
Yeah. So it's interesting, just given the 4 out of 5 strength that we got eventually, but that it's normal. I mean, that also means that we should continue to keep looking and make sure we understand, because a myositis panel will come back 2 weeks later. And you don't have any labs right now that are suggestive of myositis per se. You have like a mildly elevated AST, which sometimes can be the clue, like Jeff said, but interestingly that like the CPK and aldolase are normal. Like those are the kind of, I guess the, so then I started thinking about like amyopathic dermatomyositis, because we've really honed in on the cutaneous features of an inflammatory or dermatomyositis. And so then I start thinking like, could this be something like that's amyopathic? And again, those ulcerations that we talked about initially, like would make me concerned about an MDA5 dermatomyositis. Or you know, some of the other ones, and those generally present with interstitial lung disease, and they may have very, very subtle features of autoimmune disease but they're presenting to Dr. Connors first in the ICU, and then we see them later. So those are the things I'm thinking.
Yeah, I think anti-MDA5 is really a great thought here. You know, it comes in 2 very distinct flavors, as Melissa's pointing out. It presents either to the dermatologist's office for many, many years, or immediately to the ICU. Why people sort of respond in this bimodal way to this antibody, I don't know. It's best described in the Japanese literature, and it's becoming more common in the US and European literature. But yeah, so I agree, these antibodies really do determine, and I love the idea that we're moving away from this, let's describe the symptoms and try to, you know, turn that into a disease, and really looking and saying which antibodies is at play and what is it most likely to do. You know, we talk about the tRNA synthetases in dermatomyositis, polymyositis, the antisynthetase syndrome. The fact that we don't know all 20 of those yet, you know, means there's a lot of diseases that are poorly classified, but we have a lot of these diseases like the MDA5 that when we see them, we see this ulceration, we see the lack of the CK. You know, it really leads us down that pathway. And then there's a whole bunch of other weird ones. You know, we have people with CK elevations, but normal aldolases, which Dr. Griffin may be able to explain. I've never quite understood that, but we certainly see it clinically.
Yeah, we can see them all over, like the divide, CPK up, aldo normal, or vice versa. Or you know, you've also can see like with active myositis, if it's been going on a while, you can have normal lab values, but then even on an MRI, it looks like active myositis, or on a biopsy, it's still active. But they probably also have some burned out component because of how long it's been going on.
Yeah, and if you do look at a lot of the early criteria for these things, they contained, you know, multiple dimensions. So you could have elevated enzymes and or change in muscle biopsy and or symptomatology, because they're not uniform across this population.
And actually, one follow-up question to that point, I think it'd be really helpful if you could clarify, how does one make a diagnosis of dermatomyositis? Do you need an antibody? Is it more clinical? Could you talk a little bit about that?
Yeah, you can, there's a variety of things. So we have like classification criteria, which are more for like research to try to get more of a homogeneous group. But so we take the clinical, so like the exam, the history, all of those supporting a inflammatory myositis. And then these antibodies are generally quite accurate with that, but we occasionally have false positives, but for some of them, even for like the statin associated, they're very, very specific. But the myositis panel is helpful, plus the clinical presentation. And then we're looking for evidence of myositis with like lab evidence, physical exam evidence, and then considering like a EMG or an MRI. Like MRI is kind of the new frontier for like doing that, because none of us can get an EMG anytime inpatient, or it takes a long time outpatient. So an MRI we can get a lot faster, and we can see evidence of myositis on the MRI. And then we usually go to muscle biopsy and people who are not really, it's not classic, or if we're if the MRI is positive, but the antibodies are negative, then we might go for a muscle biopsy, but not everybody gets a muscle biopsy these days.
And I also like the idea of doing the MRI first, because it is, as Dr. Gross saying, it's a very heterogeneous disease. And if you biopsy someone absent the MRI, you can actually miss the correct spot. So getting the MRI as a guide to your biopsy is very helpful as well.
Amazing. Well, Mike, to you guys for the next aliquot.
Sounds great. Yeah, we'll break into aliquot 4. So this is kind of where a broad infectious and autoimmune workup was performed. So for an infectious workup, the team got blood cultures that showed no growth. Respiratory viral panel was negative. They did a broad zoonotic infection, including cocci antibodies, Q fever antibodies, hantavirus antibodies, Bartonella, Quintana, and Henselae antibodies, which were all negative, both IgM and IgG. The quantiferon was negative. The patient did undergo bronchoscopy, which showed 8% neutrophils, 32% lymphocytes, 39% macrophages and monocytes, and bacterial, fungal, and AFB cultures from the bronchoscopy were negative. For the autoimmune workup, the patient had an ANA that was positive, although no titer was provided. C3 was normal at 109, C4 normal at 43. A rheumatoid factor was negative, and then many of the ENAs were also negative, including SSB, RNP, anti-Smith, SCL70, double-strand DNA, chromatin, and centromere were all negative. We'll kind of pause here before we introduce the diagnostic test that was performed.
Yeah, so Dr. Griffith, would love to hear your thoughts first. What do you make of kind of the negative antibody workup so far, and what further testing would you do?
Yeah, I mean, so we have an ANA panel and we have an isolated ANA, and it sounds like no titer or no pattern to give us a clue. That's okay.
Done at an outside
Yeah,
hospital, and
yeah.
so that was not reported, was just positive.
Yeah, okay. So yeah, I mean, that's this is a relatively common thing that, and your regular ANA panel may not be overly helpful. You can have an ANA negative myositis, and you can have an ANA positive myositis. So this doesn't really rule in or rule it out. So it's just one more piece of information. You didn't say, did you say SSA was negative too?
Not yet.
Oh,
SSB
okay.
SSB was negative.
SSB was negative. So like an SSA being positive can actually correlate with like increased interstitial lung disease risk in myositis. And so like that's one thing that I was waiting to hear, but didn't hear yet. But so like a lot of our myositis, the SSA, specifically the 52, can increase that risk. The bronch, I'll defer to Jeff. I'm glad I guess I don't see bronchs all the time in these situations, so.
Yeah,
Yeah, Dr.
yeah, sure. And we don't always bronch them depending on the timing of how quickly, this can get done versus when the labs come back and if they're inpatient versus outpatient. But this is a relatively normal bronchoscopy. It is a non-infectious bronchoscopy is probably what is best to say here. So there's not a high level of neutrophils. Generally we expect a predominance of monocytes with, something like 20 to 30% lymphs and some neutrophils. And you see something like that here. And so I think this leads us down the inflammatory as opposed to infectious pathway. And then the cultures being negative is helpful as well. And I will say we don't biopsy these people via bronchoscopy. And if it's relevant and we have time, I can talk about why we don't do that later.
So I think you'll probably have the next aliquot or the last aliquot coming up next. What would you kind of send a test for, and what's both of your highest suspicion right now?
Myositis panel and an SSA. The myositis panel, just like a trick, you can, if it's sent to ARUP or Mayo, you can call those labs and have them do a stat. That's not done a lot, but if there's something reliant on that, then you can always call. And our lab will do those, not the myositis panel, but the ANAs and things. If there's like an urgency, they can go faster. Consideration of an MRI, looking for like kind of subacute myositis. Those are kind of the big things.
Yeah, I was going to agree. We get to punt here because it comes as one test effectively. If you said to us, which of the 15 antibodies do you want in which order, we would get this right some fraction of the time. I'm looking at the chat here and people are putting in anti-KU, and that's, more like pleuropulmonary fibroelastosis, but there's a ton of overlap here. And I think there's not a great way to be super elegant at this point because we don't have these diseases and their characteristics that well defined.
All right, we'll pass the mic to Evan and Sarah to hear the final aliquot.
Great. So the diagnostic test that was performed was a myositis panel. MDA5 antibody came back as high positive. The rest of the myositis panel was negative, except for SSA. 52 also came back as positive.
Yeah, would love to hear just your initial reflections on MDA5, and for people who maybe aren't familiar with that antibody, does this picture fit with kind of the amyopathic presentation you said? And would just love to hear your reflections on that.
Yeah, I think the overall picture really fits MDA5 nicely, from like the initial HPI to the exam and on with the labs and the imaging that we have. So MDA5 is, like we said, a type of myositis that can give like both cutaneous signs. So like the signs that we're seeing with the mechanics hands, the ulcerations, which is one thing that really tips the scales towards MDA5 or like a malignancy associated myositis. But these are the patients that present to Jeff first, that they present with rapidly progressive interstitial lung disease and respiratory failure. These strike a fear in the hearts of rheumatologists and pulmonologists alike, because especially this gentleman who has a high positive MDA5 and an SSA presenting with, within a month of onset of symptoms with pretty significant respiratory impairment, makes me pretty concerned about high risk for respiratory failure in general. And so there are a few tests that we use, and there's like Jeff said, there's more literature coming out of like Japan and then South Korea about these patients, and they've developed kind of a algorithm to try to stratify these into high, medium, or low risk. The high risk have a very poor prognosis with, I'm going to misremember, but like I think about 20% survive within a year, or maybe worse, but it's quite dismal. And so the high positive makes me really concerned. That's one of the factors. We also looked at like LDH and ferritin and a few other things to help us prognosticate. But he already has interstitial lung disease, and so that makes me quite worried.
Yeah, Dr. Connors, would love to hear your reflections on the final diagnosis, and if you could provide any teaching on kind of what you know about interstitial lung disease with this type of myositis.
Yeah, sure, absolutely. I agree with everything that Dr. Griffith said. This case was sort of, as I think we mentioned, sort of setting up in this direction as the antibodies, the CK and aldolase were negative. The hand ulceration really is unique. And I guess we were sort of talking in generalities. We didn't put a fine point on it, but what we saw in those pictures was Gotron sign. So that redness on the back of the extensor surfaces of the hands. The eyes were a heliotrope rash, which I don't really think it was a rash so much as a purple swelling around the eyes. And there might've been other findings, as Dr. Griffith said, had we had more pictures. But yeah, so this is a very bad prognostic case right here. So we see a fair bit of this in our medical intensive care unit, despite really aggressive amounts of immune suppression, these patients are very likely to progress. And I think, I don't know the numbers, but I think something like that, trying to salvage maybe 20% of these cases absent transplant is about right. So these are often rapidly progressive despite the use of high dose steroids, calcineurin inhibitors, et cetera. So I am also very concerned for this person. And we're already hearing, as we see the time course here, while it's not an acute respiratory failure, it's not less than 7 days, it is still rapidly progressive, which some people will call RP-ILD, but I think that's just more alphabet soup.
And then now that we're coming to the end of the session, and again, we'll transition into kind of sharing some thoughts on Rafa, but would love to turn to both of you to see if you could each highlight maybe 3 key kind of take-home points that you want people listening to this to take home with them. And give you a second to kind of think about that, but maybe Dr. Griffith, will start with you.
Sure. So I think this patient's history, I think, was already kind of pointing you towards. So it's just another reminder that the patient is telling you what's going on, and the history is really critical for all of what we do in internal medicine, and even within the subspecialties. So listen to the patient first and foremost, and then anybody like where we're starting to worry about like muscle and lung disease, have a healthy respect for these patients, because they can become sick very quickly. And so we don't sit on these MDA5 patients. We are watching them very closely and immunosuppressing them very aggressively early before they are in the ICU intubated. And then I think like just continuing to keep a broad differential for what's going on. I think the team did a really nice job of like looking into other things like infections or other things that could potentially do this, and not anchor on like one thing.
Yeah, thanks. I think my teaching points here would be the difference between subacute and acute respiratory failure. We spend a lot of time in our hospitals dealing with acute failure. This was a case of subacute failure, which has this unique differential diagnosis. I want to agree with Dr. Griffith, which is that, and I see some of the questions in the chat, what about this or that agent to use here? The answer is this is a kitchen sink kind of situation. And so, we don't have great data on when you start a steroid sparing agent. We don't have great data on when you might use something like rituximab or IVIG. But in this case, we're going to use a lot of the most quick acting things pretty aggressively up front. And the last thing I'll say from a lung standpoint is this is an otherwise healthy 50-year-old man with effectively single organ dysfunction. This is somebody who you're going to want to call transplant on very quickly, and may even end up on ECMO as a bridge to transplant.
And Sarah, Evan, or anyone else here, any kind of final questions about the case before we transition to some more reflections on Rafa? So, yeah.
Yeah, no, thank you so much for both Dr. Connors and Dr. Griffith being here and discussing this. We learned a lot by you walking us through this case. So thank you so much.
Yeah, just to echo that, I think really phenomenal discussion, Dr. Connors and Dr. Griffith, and just echoing what Sarah said, thank you so much for so authentically walking through your thought process here. I feel I learned a lot about myositis.
Yeah.
Yes, we do have one question here. Yeah, definitely.
The rash is a highly specific phenomenon. Couldn't you make a case that there's no infectious disease that would cause this? It seems like early on you knew this was somewhere on the dermatomyositis spectrum. So could an infectious process that causes a polymyositis or also have the skin manifestation?
No, I wouldn't expect that, like a heliotrope rash or mechanic's hands. Like those are all like really cluing you in and very specific, but the who knows when it's passing through all the different hands what was clued into, and so they probably were working up everything initially, but
we will admire thoroughly.
Yes,
There should be that cerebral event that this characteristic rash speaks powerfully against those diagnoses.
Yes, exactly. So I would say that's a great clue that you're on the right track for more of a dermatomyositis for sure.
And I think the reason that comment's really helpful in the sense that you don't want to waste time looking for every last infection in this person before you start immune suppression. I think that would be the mistake to make is, I don't even know that we would have necessarily had to bronch this person. It's fine that it happened, but I certainly wouldn't have delayed immune suppression to do it.
Yeah, I would agree that like this really is, I mean, what you're seeing on the CT and the overall picture wouldn't make me stop and say, I need a bronch before I do that. I think they definitely, the times that I do that with, is there a malignancy because like of the way that it looks? Occasionally we've had like myositis patients present with like a lung cancer. And so we're trying to figure out, what's going on. But for this patient, I wouldn't necessarily need it.
Well,
There's
thank
a lot
you
of
both
questions
again.
about there's questions about why respiratory
please.
failure. This is a bit unknown, but a lot of these, especially in the anti-synthetase syndrome, these are actually attacking DNA formation. So, they're attacking the tRNA synthetases, which are those things that bring the proteins together to form the DNA. And you disrupt that, you end up with all sorts of fibrosis and things. So I would say, I'm not a basic science expert. Most may have a better answer, but this is actually getting at a very fundamental level of disruption of repair and growth.
Yeah, and we're not entirely sure, but we do know that MDA5 has a very similar presentation to severe COVID, and the way that the MDA5 works intracellularly and with viral infections leads to like massive interferon response. But so why exactly we're still learning, and actually COVID's been teaching us a lot about MDA5.
Amazing. Well, really phenomenal teaching from both of you. And thank you so much for taking the time to discuss this case. And I think I now wanted to bring kind of Rafa back to the center of this discussion. And as I mentioned a little bit at the beginning, he was really the one who helped to spearhead these types of subspecialty series. And of course, today's session and all of the future Monday sessions are in honor of him. We have a team, myself and several other people on the CP Solvers team who help to coordinate the Monday subspecialty sessions that are every single Monday hosted by CP Solvers. I'll put maybe my email in the chat, and if anyone who's tuning in, whether a resident, attending, medical student, wants to present a case on one of these Monday sessions or volunteer as a case discussant, we host these every Monday, so we continue to do this series in honor of Rafa. And here we can see a lot of beautiful photos of him. And I now really wanted to kind of open this space for anyone to unmute if they feel comfortable to share any memories, reflections, just what Rafa meant to them. Of course, there's no pressure, but this is the space if you want it to. I know Dr. Ravi Singh, one of Rafa's mentors, was potentially interested in speaking. Ravi, I'm not sure if you're still on the Zoom or if you had to jump off. Are you there and available and interested in saying a few words?
Yeah, I'm here.
Would you like to? Hi, Ravi. Nice to see you.
Nice to see you. Thank you for inviting me to come up and speak a few words. And I kind of feel like it was just yesterday. He was sitting to my left here, presenting a case of leishmaniasis. He also presented me a very difficult case on myositis. So this was sort of a trip down memory lane. But going back a few years, we met on CPS initially, and we both definitely, all of us here, all the team that you see, the wonderful team in these pictures here, we definitely all shared a love of medicine. And from the start, I could see that he was very smart, also a very caring person, and he was very determined to pursue his dreams of obtaining a medical residency position in the United States. So he used to reach out to me in the chat and ask, once he found out I could offer some mentorship as a APD in my program. So we both collaborated on this IMG project, and which has become very integral to CPS and is very successful. And many IMGs that apply to US residencies have benefited from his ideas, especially these mock interviews and the sessions on CV building and application information. And many applicants every year that I interview will tell me because of Rafa, I am able to sit here and give an interview and know how to present myself on an interview, say, or build my CV. So Rafa's legacy definitely lives on in all these applicants who share the same dream that he had several years ago. A story regarding Rafa, like I always remember, there's one interesting thing. I became an expert in winter coats because of him, because when he arrived to do a rotation with me back in February 2022, it was snowing. That's the first time he saw snow, so he was very excited. He took a picture out in the snow. So I'm like, well, Rafa, why don't you have a coat? He's like, I just stepped off a plane in Dulles in DC from sunny Brazil where it was 86 degrees. So I immediately took him to the mall to buy him a winter jacket. And then I think it was the first or second weekend he came up to see you, Maddie, in New York. So I was kind of worried he's going to go up to wintry New York and have no jacket. Then he came back last year to do his step 3. And again, he didn't have a winter jacket. So then he was telling me about going to Chicago where it's extremely cold and he didn't have a jacket again. So he went off to the mall to buy another winter jacket. So because of him, I've become an expert in finding winter jackets on sale. So if there's any students that want a winter jacket, let me know. I will definitely help you with that, courtesy of Rafa. But I would say that Rafa's legacy continues on in this platform. As long as this platform exists, we will continue to remember Rafa and honor his valuable contributions and his tireless efforts in helping applicants succeed. In every applicant who finds their way, in every student who learns and grows, his spirit lives on. Even yesterday, I drove by the Prometric testing center where he took step 3, and I couldn't help but think about that. I forgot about this session, but there are certain spaces where I see him, where he existed, and it brings back memories. So I really appreciate you having this session. I also thank University of Colorado for matching Rafa into your program. He was extremely happy and excited. And as exemplified by this demonstration today of this case and the in-depth discussion, he would have been very happy at your institution because that's the level that he aspired to. And I thank the team. Thank you, Maddie, for having this session to remember Rafa and continue to have his legacy live on this platform.
Ravi, thank you so much. And everyone in CP Solvers knows, but Ravi is such a huge advocate for IMGs, yes, but even beyond that, anyone who reaches out and needs help. So Ravi, you are such an amazing support. I know for Rafa, but for so many people. So we all appreciate you. Again, the space is open. Gabriel, Rafa's brother, I'm not sure if you're still on. If you would like to speak, please unmute. I'll give a few seconds for Gabriel to unmute if he would like to do so. And if he's still here, I can't necessarily see from the chat. If not, I see that we have someone else raising their hand, but we'll just give a few seconds in case Gabriel is here and wants to say something.
Mary, I could translate what Ravi said for Rafa's
Yeah.
mom.
Deborah, that would be great. Do you mind translating? Thank you so much for offering.
I took some
Okay.
notes. I hope we'll go kind of the basics that Ravi said. O Dr. Ravi, ele agradeceu pelo convite, por esse episódio lindo que estamos fazendo para o Rafa, e falou que é como se fosse ontem que o Rafa estava sentado do lado dele, apresentando casos, e o Rafael foi, né, lá para a cidade de Baltimore e pôde ter uma experiência com ele, e o Rafael, o Dr. Ravi, ressaltou o quanto o Rafael era uma pessoa inteligente, determinado, o quanto ele lutava, né, para alcançar o sonho de ir para os Estados Unidos fazer medicina, ser médico, fazer a residência. E com isso eles criaram, né, um projeto para ajudar médicos de todo mundo a entrar na residência nos Estados Unidos. E por causa disso, muitas pessoas compartilham o legado e falam quanto o Rafa ajudou, quanto aprendeu ou assistiu algum vídeo que o Rafa organizou algo para dedicado especialmente para as pessoas poderem entrar nos Estados Unidos. E a última história que o Ravi contou foi que ele chegou nos Estados Unidos sem um casaco e estava muito frio. Ele ia para a neve em Chicago e eles tiveram que comprar um casaco porque ele vinha do Brasil com roupas do Brasil, que lá faz muito calor, e nada, o Ravi se tornou um especialista em comprar casacos para ajudar o Rafa. O legado, né, que o Rafa deixou é muito grande, e até hoje a gente pode ver que tem muito impacto e que ajuda muitos estudantes, médicos e pessoas do mundo todo que querem se mudar para os Estados Unidos.
Thank you so much, Deborah. That was amazing. I believe I saw that Gabrielle may have rejoined. Gabrielle, if you would like to say something, I just wanted to make the space for that. No pressure at all if you are not in a place where you would like to say something. The space is yours if you would like.
Hi, can everyone hear me?
Yes. Thank you so much.
Thank you. Thanks so much for Apurva to contact me and send me the link. I've been so proactive, like messaging me if I want to join, and included myself on this meeting. So the introduction was very moving. I would say it's really nice to always reaffirm how Rafael was so important in the field and the impact he caused to everyone in such a short period of time. It's really sad that this was caught such in a tragic way. But I was texting his friend Milena, which was in the call as well earlier, and then she said that they used to walk in a huge park we have in our seat, and they would speak in English and pretend they were in Central Park. So that was really a big dream that he had. So, and to know that he realized that dream, it's really comforting in our hearts for sure. Rafa always being inspirational and got so much out of almost nothing. He could do so many amazing things and inspire so many people. So I'm really grateful that he's being honored today. Thank you so much for everyone for doing that. Thank you.
Thank you so much, Gabrielle. It's so good to see you here. I believe I saw a hand raised before. I'm not sure if they're still here and I didn't quite catch the name. But if anyone else would like to say any words, the space is open.
Yeah, and so it was probably me. And here's Tomas. Yeah. And here's Tomas, one of the incoming interns. And I just wanted to share with you guys that I didn't meet on Rafael in person. I got to have some online interactions with him, and he was always very kind and very helpful. And I know that the fact I'm here today is one of the reasons why he matched here last year. So I just want to express my grateful for him. And indeed, I'm actually going to an IMG section for the orientation week. So I found that, sorry for the noise, I'm just waiting for the bus, but I just found that it would be very nice to recognize for his family how helpful he was for all of us IMGs, and I think that's it. He was a very, very nice guy. I really enjoy our interactions I had with him, and I hope me and the other Brazilian folks in the program, we can honor his history here in the program as well. Thank you.
Thank you so much. That was very beautiful. If anyone else would like to speak, the space is open. If not, no problem. I'll be silent for a few more seconds for anyone else who wants to say something. If not, we'll end the session.
I think I just wanted to say that Rafa certainly has made huge difference in our program. And Tomas highlights that. Our focus on international graduates, our focus on making sure that when people get here, they are oriented, comfortable, that they find a welcoming environment. I think that's all part of his legacy. And I had a chance to speak with Gabrielle and such during this process, and I know how hard this has been. And I think I want everyone to know that, our honoring of his legacy goes, even beyond this. All of our classes wear pins with his name on it in the colors of Brazil that say "One Life, So Many Dreams." I get asked about that pin probably once a week, and so we talk about Rafa all the time here. His white coat that he was going to be receiving when he got here is framed in our offices, and so I want his family especially to know, but everybody out there, his legacy very much lives on in our very active members.
And as we close out, I just wanted to say thank you so much to Maddie for all you have done for this session. You have put in a ton of work to make this happen, all with starting intern year. So thank you so much.
Well, thank you all so much for being here, and huge thank you to Dr. Griffith and Dr. Connors for discussing, and for Sarah Evanaporva for helping to organize this. As Dr. Connors said, Rafa's legacy definitely lives on both at University of Colorado within CP Solvers, and yeah, we're definitely thinking of him, and the world shines brighter because he was in it. And thank you all for being here. We'll end the session there. Bye.